Well, thank you for the invitation to speak today. I think this is a topic that has not gotten as much attention as some other topics. And I think this is mostly because in the last decade, we've done such a better job at having these children grow into teenagers and into adulthood. And it's time that we focus on some more maintenance of health topics, such as bone health in pediatric patients. So these are my disclosures. And our objectives for today are going to be to understand the importance of monitoring bone health in children with intestinal failure, identifying factors which contribute to reduced bone mineral density in pediatric intestinal failure, describe how we evaluate bone health in children, and then determine the best approaches to managing bone health in pediatric patients with intestinal failure. So I'm going to start off with a case that I had a few years ago. So this was a 3-year-old girl with short bowel syndrome on TPN since birth. And I just wrote over here that just to remind everybody what the definition of intestinal failure is. So these are children and adults that are dependent on IV supplementation to maintain adequate health and growth. So she presented to the emergency department with irritability and refusal to bear weight. She was afebrile. Basic lab evaluation was normal. And we got some imaging here. We are not radiologists. I don't expect anybody to be able to really interpret these. These are kind of subtle findings. That's why we have radiologists that look at this. But she had buccal fractures of the fibular diaphysis and distal tibial metadiaphysis. They noted osteopenia, so low bone density, and mild widening of the physis associated with findings that are compatible with rickets. So what is metabolic bone disease in intestinal failure? So the definition is an alteration in skeletal homeostasis that results in defective bone density, such as osteoporosis, and defective bone mineralization, such as rickets. In children with intestinal failure, this is a major multifactorial complication, and we'll go through the different causes of this throughout the talk today. Several studies have shown an increased risk for low bone mineral density in children with intestinal failure that are on home parenteral nutrition. There are different definitions of what a low bone mineral density is, but this is the generally accepted one. So this is defined by a Z-score of less than or equal to -2 on a DEXA scan. And one important note that's not always done in these interpretations is that the DEXA scans have to be adjusted for short stature, which is seen in about half of the patients that we follow. In children, it's thought that about 45% have osteopenia and 16 to 25% have osteoporosis. In adults, the percentages are much higher, so 57 to 88% do have findings of osteoporosis. So the imaging that we use to define low bone density is a DEXA scan. So this is dual energy X-ray absorptiometry. So this is X-ray beams from 2 different sources that are aimed through the patient's body. And what we do in pediatrics is look at the lumbar spine, looking at the left and right hip, and the left and right femoral neck. So you get measurements of bone mineral content, bone area, and the most important thing that we focus on is bone mineral density. There are many advantages to doing this study. It's a rapid test, usually pretty easy to get children to do it, even if they're not the most compliant. It's like an X-ray machine, has low radiation, it's precise, inexpensive, and it looks at different bone sites. So it's recommended that DEXA scans be performed in children and adolescents that may benefit from interventions to reduce the risk of a clinically significant fracture. And this is a sample DEXA report for one of my patients. And you can see over here that in all of the sites that are measured, the Z-score is significantly lower than significantly lower than -2. So this patient has low bone density at all sites that are looked at. In adults, the definition is a little bit different, so I just want to take a moment to speak about this. So it's based on the WHO criteria looking at a different measurement score, which is called the T-score. And normal scores are greater than -1. They define osteopenia as -1 to 2.5, and osteoporosis as less than or equal to -2.5. In children, it's a little bit different. So in 2019, there's an International Society for Clinical Densitometry that issued a pediatric position statement defining osteoporosis in children and adolescents. So in children and adolescents, we don't base it just on the Z-score. When the Z-score is low, we call that low bone mineral density, but the actual definition of osteoporosis has to also include clinically significant fractures. And they define this as 2 or more long bone fractures by age 10, 3 or more long bone fractures by age 19, or a vertebral compression fracture. And we don't use the term osteopenia in the DEXA reports. In children and in adults, if you have a normal DEXA scan with a normal Z-score or a normal T-score, that does not mean that these children or adults are not at risk for getting fractures. So it's not a be-all and end-all test. So what are the causes of metabolic bone disease in pediatric intestinal failure? So in children with intestinal failure and intestinal insufficiency, so these are children that are dependent on parenteral nutrition and children that have weaned off parenteral nutrition and are still dependent on enteral and oral nutritional supplements. Both of these populations are at risk for developing metabolic bone disease. This is because partly there's a high risk of micronutrient deficiencies in these populations, which we know are essential for growth and maintenance of skeletal mass. Some of the factors in this population that contribute to metabolic bone disease are malabsorption of the essential micronutrients and minerals, renal calcium wasting, chronic metabolic acidosis, which is due to loss of bicarb and high stool output, and D-lactic acidosis, which we see in small intestinal bacterial overgrowth. There is a genetic component to this. A lot of these children have very minimal physical activity. A lot of them also have chronic intestinal inflammation. And long-term parenteral nutrition is a potential factor as well. So we don't have a lot of data on the incidence and risk factors of low bone mineral density in children with intestinal failure, but I will go through some of the studies that do exist. And why is this so important in children? So as I mentioned before, in previous years, we were really just taking care of the acute factors that were causing morbidity and mortality in these infants and young children. Now that we're doing a much better job of getting them into adolescence, into adulthood, we really have to take care of other problems such as bone health. So loss of bone mineral density is more detrimental in children as the insult that occurs during childhood coincides with a time of maximal bone mass accrual in a child's development. So if these children do not accrue this bone mass at this critical period during childhood, it's going to result in long-term osteopenia with its morbidities that are going to be very difficult to reverse once they reach adulthood. So therefore, we have to ensure that optimal bone mineral density is achieved in these pediatric patients with intestinal failure. So I was recently on a trip. This is just a sunset view of Bryce Canyon. So just a reminder that we don't want to let the sun set on the opportunity to intervene for these children's bone health. This is an overview of the causes of metabolic bone disease in children with intestinal failure. We often think of vitamin D deficiency as one of the major causes. A lot of these children with short bowel syndrome have malabsorption. They are deficient in vitamin D. There's significant lack of sun exposure. In general, in all children, it's definitely gotten worse over the last year with everyone being indoors and doing remote learning. We supplement these children with high doses of oral vitamin D3. Hypocalcemia is a cause. This is partly due to malabsorption or vitamin D deficiency. It can also be due to increased urinary calcium excretion. So we do want to make sure that these children are meeting their calcium needs both orally and in the PN. Vitamin C deficiency is not a common cause that we typically think of, but it can occur during multivitamin shortages or if the nutrition is very poor. So it's something that we have started checking more frequently, especially in the last year with all the multivitamin shortages. Hypophosphatemia, this can be due to malabsorption, inadequate dietary intake, or excessive oral calcium intake. And there are also some forms of parenteral iron that can actually result in some hypophosphatemia. So we treat this by making sure that the phosphate is increased in the PN or supplementing them orally or enterally. And the form of iron that we want to use in this population is IV iron sucrose. Copper deficiency is another cause. In patients that have cholestasis, we tend to limit the copper and some people will take it out completely. It's an issue when we have PN shortages as well. So we want to make sure that we're supplementing the copper and make sure that we're not giving copper together with zinc as they do compete for absorption, and giving zinc simultaneously with copper can result in copper deficiency. There's aluminum toxicity, so we're not intentionally giving aluminum to any of our patients, but there is contamination in the parenteral nutrition. So if patients do have high aluminum levels, we might want to change some of the formulations that we use in the PN. There's fluoride toxicity that can occur. This is not typically something that we see in the US, but it can be seen in some drinks that are very high in fluoride. So we want to make sure that we're using recognized isotonic drinks. And then underlying inflammation. So if a patient has an inflammatory burden of disease, such as inflammatory bowel disease or just chronic intestinal inflammation, that can also contribute to metabolic bone disease. So looking at vitamin D deficiency, it's defined as a level less than 20, and vitamin D insufficiency is defined as a level between 20 and 29. We care about both of these because we know that both of these can affect the children's bone health. And there's a much higher incidence of vitamin D deficiency in short bowel syndrome patients, especially when they have very short intestines. We know that vitamin D is important for bone growth and skeletal development. And vitamin D increases calcium absorption from the gut when it is deposited in the bone. Where do we get vitamin D from? So we get it from the sun, from UVB light that activates the synthesis in the skin. We get it from the diet, so milk or juice that's enriched in vitamin D. And one important thing to note is that in the PN formulation, there actually is not a lot of vitamin D. In the adult multivitamin injection, there's only 200 IUs or 5 mcgs. And in the pediatric injection, there are 400 IUs or 10 mcgs. And we used to talk about vitamin D in international units, and now there's a shift towards micrograms. So I listed both over here since we are used to report more in international units. So definitely not enough, and there is no injectable form of vitamin D available. We check vitamin D status by looking at the 25-hydroxy form, also looking at serum calcium and PTH levels. We have 2 formulations of vitamin D that we can use to treat. There's vitamin D2, ergocalciferol, or vitamin D3. We prefer to use the vitamin D3 because it's more effective and it's absorbed more, but sometimes it is more expensive to use. The common starting dose that we use is 50,000 units or 1.25 milligrams once a week to try to correct a deficiency. And then daily doses can vary greatly depending on the child and their absorption. So in patients with significant malabsorption, we sometimes have to use very high doses. So just keep going until you correct the deficiency. So sometimes even just 50,000 units daily I've had to use. So is there an association between vitamin D deficiency and low bone mineral density in children with intestinal failure? So I'm going to go through some of the studies. So it's actually interesting that vitamin D deficiency by itself has not been shown to be associated with low bone mineral density. This is a review of vitamin D status and DEXA scans in 123 patients over the age of 3. 12.5% of the patients had low bone mineral density, but interestingly, they did not find an association between low bone density and vitamin D deficiency. They did find an association between exclusive parenteral nutrition in an age greater than 10 years with low bone mineral density. And this is a logistic regression model. And you can just see over here that as children get older, they do have an increase in vitamin D deficiency and an increase in low bone mineral density. But they, again, were not directly associated with one another. Another study looked at DEXA scans in 65 children over a 9-year period. They found that 34% of the children had low bone mineral density. One important note is that they did not correct those Z-scores for short stature. As I mentioned before, we need to do that. So there might be a limitation here in how accurate this incidence really was. They found that 41% of the children had vitamin D deficiency, but again, no association was seen with low bone mineral density. Another interesting finding is that 29% of the patients had at least one fracture, but that did not correlate with low bone mineral density either. The factors that they found that were independent predictors of low bone density were a low serum calcium level and low weight for HZ scores. So this study concluded that the overall nutritional well-being is associated with improved skeletal health. We have to maintain adequate calcium reserves for optimal bone mineralization. And again, the reason that this is so important is that there's leukopenia as these children reach adulthood. And at that point, it's going to be a lot more difficult to reverse. So moving on to TPN as a potential association with low bone density. So there are some mixed findings in children on this. So one study looked at 36 children with intestinal failure. Half of the children had a low bone density score. Here they defined it differently. So they defined it as a Z-score less than -1 and not -2. And a lot of these children had actually already weaned off PN by the time they had their first DEXA scan. So keeping in mind that children that are no longer dependent on PN might still be at risk. A big portion of the population in this study, 64%, had vitamin D deficiency. Again, interestingly, no association was found with low bone density. And also interesting that supplementing these children with vitamin D did not improve their bone density Z-scores. They only predictor that they found was actually the number of years on PN. So the longer you were on PN, the more it predicted having a low bone density. And no children less than 16 months had any low bone density scores. They also found that 11% of the children had a pathological fracture, 19% had bone pain. Neither one of these correlated with a low bone density. So the conclusion, I think, from a lot of these studies is that we really need larger controlled studies to make significant conclusions. And then again, supplementing these children with vitamin D did not seem to improve their low bone density scores. They also noted that there are promising approaches such as bisphosphonate and GLP-2 therapy, which I'll touch upon later, that should be looked at in pediatric intestinal failure, as there is some data in adults that this might be a potential treatment option. Another study looked at what happens when you wean off PN and low bone density. So this was a study looking at 41 children with intestinal failure. Majority of the children had actually weaned off of PN several years ago. 70% had low bone density scores, again, defined as -1, less than -1. And this was both during weaning and after weaning off parenteral nutrition. And they found that the significant predictors were time after weaning off parenteral nutrition, the duration of parenteral nutrition, and again, low calcium intake, which was seen in the previous study. Vitamin D deficiency and secondary hyperparathyroidism did not have an association with low bone density. So they concluded in this study that bone mineral density, vitamin D, calcium, and nutritional status should be closely monitored during and importantly after weaning off parenteral nutrition to make sure that you're giving significant sufficient vitamin D and mineral substitution for normal growth and bone mass attainment. Again, a lot of these studies do recommend giving vitamin D and making sure that children are not deficient, because I find it hard to believe that vitamin D status does not affect your bone health. And then another study looked at what happens off of parenteral nutrition. So they looked at 31 children on PN, and they actually found an interesting finding was that the bone mineral content actually improved the longer you were on parenteral nutrition. Why could this possibly happen? I think it's because we're probably meeting the calcium needs better in parenteral nutrition than sometimes we do just on oral and enteral nutrition. And they also found that the risk of low bone mass decreased with an odds ratio of 0.9. So PN was actually beneficial in this population. Low bone mineral density is common in pediatric intestinal failure. And they said that bone mass could actually improve during parenteral nutrition in these children. So again, we have to pay attention to these children when we wean them off parenteral nutrition, if this is truly the case. Another study looked at low bone mineral density and concluded that in children, it's not associated with a level of PN dependency. So this was a study looking at 40 children that were on PN for at least 2 years. They did correct for short stature in this study, so it's a little bit more accurate. And they found a higher risk of low bone density with congenital enteropathy versus short bowel syndrome and pseudoobstruction. Only 2 children had bone fractures in this study. Those children, interestingly, had normal Z-scores on the DEXA scans and normal vitamin D levels. So they found that the length of time on PN and higher dependence on PN did not impact bone mineral density. So again, I think it's hard to come up with what is actually true from these studies because they're such small studies that have conflicting findings. So what about other micronutrient deficiencies? So let's look at what research has been done on those topics. So copper deficiency is a big one in bone health. Copper is absorbed in the stomach and the proximal small intestine and has a role in bone health because it promotes osteogenesis. Copper deficiency can lead to anemia, neutropenia, as well as metabolic bone disease. And this is due to increased bone resorption, weakened bone formation, and reduced bone mineralization. There's an adult study on copper deficiency, and they found that low serum copper was associated with reduced bone mineral density, as well as increased incidence of fractures. This study was not repeated in pediatrics, so we don't have data to conclude anything in pediatrics, but we know that copper is very important for bone health. So we want to prevent deficiency if we can and treat it when we find it. So why do these patients become deficient in copper? So most of the time it's because we're purposely limiting it. Again, in patients that have cholestasis, copper can be hepatotoxic. So we usually tend to decrease the copper by 50%. We want to be careful not to remove copper completely from the parenteral nutrition and to pay attention to copper levels when there are shortages. So we recommend checking copper as well as ceruloplasmin every 6 months and every 3 months if it's abnormal. We add on ceruloplasmin because this helps us measure a more accurate form of copper, which is called a free copper level. And then if copper deficiency is suspected, we recommend skeletal surveys to look at bone health. Treatment is a little bit tricky. So there are oral pills that you can give. You can supplement with IV forms of copper. There aren't good compounded forms of copper, and so into liquids, it's quite hard to find, and it's not really well tolerated. In some of these deficiencies, you can actually give the IV form enterally. And again, important to note that copper does compete with zinc for absorption, so you don't want to give copper and zinc at the same time. What about vitamin K deficiency in bone health? So vitamin K is an essential cofactor for bone-related vitamin K-dependent proteins. There's no data on this in children. There's some data in adults that we think that vitamin K deficiency can impact bone metabolism and decrease bone mineralization. There's a potential increased fracture risk in some of the studies. And one study looked at vitamin K supplementation in adult patients on home parenteral nutrition, and they found a trend for higher bone mineral density. How do we check for vitamin K deficiency? So the actual more accurate form is to test for it is really hard to find in labs. So we monitor it indirectly with a prothrombin time with INR. And we can supplement vitamin K in parenteral nutrition as an IV additive, or give it orally or enterally if we need to. What about some additional vitamins and minerals for bone health? So iron plays a role, and deficiency in iron could lead to increased bone fragility. Zinc is a stimulator for overall growth. It's an important cofactor. It increases activity of osteoblasts, which build up the bone, activates bone formation, promotes collagen synthesis, and prevents absorption by osteoclasts. Selenium can also affect cartilage integrity. Again, there's not a lot of studies that were done on these topics, so a lot of this is more hypothetical data, suggesting that these do play a role. And vitamin C, we do know can cause scurvy. And again, it's not something that we typically see, but it has occurred with the multivitamin shortages, or when when patients wean off of parenteral nutrition, if the diet is very poor, these patients can have vitamin C deficiency. So scurvy can present as lower leg pain and refusal to bear weight in children. And it can cause subperiosteal hemorrhages as a result of collagen defects. Okay, so moving on to monitoring for bone health in children with intestinal failure, as well as insufficiency. Again, very important in the insufficiency group as well. So we start off, like we do with a lot of other things, with a history and physical exam. Important to note that most patients with low bone mineral density will be asymptomatic. If there's a history of any bone fractures from minor trauma, it's going to make you very suspicious that their bones are fragile. If there's bone pain, refusal to bear weight, you do want to image these children. You want to work closely with a dietitian, making sure that their children are meeting the DRI for calcium, both through enteral and parenteral nutrition. Again, I often find that through enteral and oral nutrition, it's much harder. We often do need to supplement these children because they're not getting enough, either from formula or from the diet. You want to do a thorough review of the medications that they're on. There are some medications that can impact bone mineral density, for example, steroids or loop diuretics. You want to look for physical signs of vitamin and mineral deficiencies, review the growth charts and growth velocity. The baseline lab evaluation that we do is checking electrolytes, magnesium, phosphorus, ionized calcium, checking alkaline phosphatase. We tend to think of high alkaline phosphatase as coming from liver in these patients, but it can also come from bone. So what you can do if you have a high alkaline phosphatase level is check alkaline phosphatase isoenzymes, which will tell you what proportion of the alkaline phosphatase is coming from bone versus liver. So it'll help direct you as to the etiology. We want to make sure that we're checking the vitamin D25 hydroxy status. The 125 form has no role when we're looking at nutritional vitamin D status. Checking parathyroid hormone, vitamin C if you're suspecting a nutritional deficiency or when there might multivitamin shortages, checking your zinc, copper, and ceruloplasmin and selenium, checking the INR looking for vitamin K deficiency, and then looking at urine calcium to creatinine ratios to check for excess urinary calcium excretion. We want to get some general x-rays that can give us some clues if a child has rickets, and if there's any abnormalities in the bones, checking a bone age, checking your DEXA scans. So we recommend doing a baseline evaluation at age 4 to 5, and then repeating it every 1 to 2 years. You want to make sure that these DEXA scans are being read by an endocrinologist that can give you interpretation with Z-scores. If you do it in some centers, that just have a radiologist. They're not going to give you a Z-score, and then you're not going to be able to interpret those DEXA scans. And how do we manage low bone mineral density? So if patients have findings on imaging, again, you want to do your baseline lab evaluation, making sure that you're maximizing their calcium, phosphorus, and vitamin D intake. So whatever you can through parenteral nutrition, and then the rest through oral and enteral. Doing a thorough review of the medications, again, minimizing any medications that might have a negative impact on bone health, such as steroids, checking your baseline DEXA scans and repeating them. And then a very important thing is consulting endocrinology. So we are not experts in bone health. We don't want to pretend to be experts in this. We're experts in other things, but not in bone health. So we want to remember that we do have colleagues that are very experienced in this and have them see these patients. So I generally refer all patients that I have any suspicion whatsoever. If the DEXA scans are abnormal, if they have any sort of low bone density, if these children are not growing well in height, and I know that their nutritional status is adequate, just refer them early on to endocrinology so they can follow them. There might be a role for bisphosphonates that can decrease bone resorption, so we leave that to the endocrinologist to manage, again, because we are not experts in this. And then there are exercises that can be done. So this can help treat low bone density, can also help prevent it. So these are weight-bearing exercises that make the bones work against gravity, such as walking or climbing stairs. Most of these children are really inactive. Again, it's been compounded so much in the last year by everyone being at home. So really making sure that they're participating in these exercises as much as possible. The goal is 30 minutes a day for 5 to 7 days a week. And these are some examples that we tell our patients to do. This is divided based on age. So some things that are appropriate for preschool age, such as playing hopscotch, jumping jacks. Elementary school children can do shuttle runs, balance and hop. Older children can do assisted squats. They can do jumps, push-ups, bicep curls. And then the most simple thing, just walk. If they can't do any of these things, if it's too much for them to do the jumping, just make sure they're walking. And this is me in Death Valley practicing my weight-bearing jumps. So moving on to bisphosphonates, again, I would leave this to the endocrinologist. I am by no means an expert on this, but what they do is they slow bone resorption by reducing osteoclast function. They're oral and IV forms. They're used extensively in adults, especially in postmenopausal osteoporosis and in steroid-induced osteoporosis, as well as some other bone diseases. We don't really know fully what the adverse effects are in children on the growing skeleton. So that has limited their use in pediatric patients. And this is a review from 2014 that mentioned that the use of bisphosphonates in pediatric patients should be carefully weighed to ensure that the potential benefits to bone health outweigh any potential risks. And they concluded that there's insufficient evidence for the routine use of bisphosphonates in clinical care. And again, therefore, treatment with this should be regulated by endocrinologists that have experience in managing bone disease in pediatric patients. And then just one final thought on GLP-2. So we have started using GLP-2 agonists to nucleotide in a lot of our patients with short bowel syndrome that are dependent on parenteral support. GLP-2 is an intestinotrophic hormone that's produced by L cells in the distal ileum and proximal colon that increases absorption. And there's some data that implicates GLP-2 as a potential mediator on the effects of nutrition on bone metabolism, particularly on suppression of bone resorption. GLP-2's role on bone remodeling has been studied very minimally in adults. There's some studies in postmenopausal women and 2 studies in short bowel syndrome. So in postmenopausal women, they did find that treatment with GLP-2 resulted in a significant dose-dependent increase in total hip bone mineral density over the course of the study, and this was in the higher dose that they gave. And then short bowel syndrome, again, really only 2 studies that were done by the same group. One looked at a bone resorption marker called C-terminal telatopeptide in response to a meal, and they compared it with plasma concentrations of GLP-2. And they found that in short bowel syndrome patients without a colon, they did not have a reduction in the serum concentration of this marker when compared to normal controls, and there were increases in GLP-2 levels, and they suggested that bone resorption is decreased postprandially by some intestinal factors, and that GLP-2 might be a possible candidate for what those intestinal factors are. And then they did a subsequent pilot study in 8 adult patients with short bowel syndrome, and they did not see any decrease in bone resorption with GLP-2 treatment. Again, very, very small study. We need more data on this. So our take-home messages are that patients with intestinal failure as well as intestinal insufficiency should be routinely monitored for metabolic bone disease. And important to note that patients should be monitored even after PN is weaned, and they might be at higher risk for low bone mineral density after they're off of PN. Bone health assessments should be done frequently. So looking at your history and physical exams, assessing the risk, monitoring baseline labs. DEXA scans should be part of a comprehensive skeletal health assessment in all patients on long-term parenteral nutrition. We don't have evidence to indicate how often these DEXA scans should be performed, but again, we start doing them at age 4 to 5 and then repeating them every 1 to 2 years thereafter. We want to optimize calcium intake, serum calcium levels, optimizing our weight for age Z-scores. And again, I find it hard to believe that vitamin D status does not play a role. So I think we should optimize vitamin D status and make sure that we're keeping patients at normal levels. PN does not seem to be a risk factor for metabolic bone disease, but we do want to optimize our PN formulation to minimize hypercalciuria. So we want to provide adequate calcium, phosphorus, magnesium, and acetate, and avoid excessive protein and aluminum contamination. Very important, we want to consider referral of these patients that have low bone mineral density and osteoporosis to endocrinology. Encouraging physical therapy and weight-bearing exercise, both for prevention of metabolic bone disease and for treatment. And again, looking at this potential role of intestinal growth hormones on bone mineral density, the data is so minimal at this point, but I think it would be a very interesting thing to look at. So we do need additional prospective large-scale multi-center studies to identify the risk factors for low bone mineral density and determine optimal monitoring for bone health. These are my references, and we'll take any questions in the Q&A. Thank you.